Hello, everyone. I'd like to welcome everyone to the January 14th meeting of the Mississippi State Board of Health. Appreciate y'all coming up here and appreciate your commitment to the public health of our state and our citizens. I'd like to begin with an opening prayer. Dr. Davis, you give a good prayer, and you give our opening prayer. And if everyone would stand for that, and we'll also do the Pledge of Allegiance.
Yeah, happy to do so, Doctor. Let's pray. Father, I thank you for the privilege to gather together here. And I thank you for the mission of this board and the mission of this health department. Lord, I pray that you would give us wisdom and insight and help us to make good decisions that benefit citizens of the state of Mississippi. Pray for diligent on our part as we work through this agenda. Father, we're particularly grateful today for the men and women of the Mississippi State Department of Health and the hard work that is put in on a daily basis to make Mississippians have more satisfying, healthy, and enjoyable lives. Thanks again for the privilege of serving on this board. In Christ's name I pray. Amen.
Now for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. You may be seated. I'd like to start, we've just done the opening prayer and the Pledge of Allegiance, and the board member who recommended those two things be added to our ritual is Bobby Moody, who has been an outstanding member of this board for many years, who also few Mississippians have contributed as much in a variety of ways to the public health of Mississippians than Bobby Moody, certainly during his legislative career and leadership. But this board did not want him to leave without appropriate recognition of our appreciation for him, not only his service to this board, but to the citizens of our state. And I'd like to read a resolution that the board created. Bobby, I have to put my glasses on, so forgive me. This is a resolution in recognition and appreciation of the distinguished service of Robert Bobby J. Moody. Whereas Robert Bobby J. Moody, Board of Health member for the Mississippi State Department of Health, retired on June 30th, 2025, after more than 11 years of service to public health. And whereas Bobby Moody, along with his wife Ann, started Moody Farms in 1973, which continues to operate and expand, and he operated Moody Cotton Gin and Noxipator from 1992 to 2002. And whereas Bobby Moody was named Winston County Farmer of the Year 3 times, 1976, 1993, and 2000. Winston County Outstanding Conservation Farmer, 1999, and Winston County Man of the Year in 1999. And whereas Bobby Moody served as FSA County Chairman from 1974 to 1983, and a Louisville Public School Board member from 2009 to 2014. Public school board member may be the most difficult service you ever had. I've served on a school board, I still do. Whereas Bobby Moody has been a Winston County Farm Bureau board member for 40 years, serving as president of the board for 8 of those years, and served on the Mississippi Farm Bureau board. And whereas Bobby Moody has been a deacon at Good Hope Baptist Church for over 40 years, and he has served in the Mississippi House of Representatives as District 43 representative from 1984 until 2002, served on several committees, including Chairman of Public Health and Welfare, Chairman of Forestry, and a member of Ways and Means and Agriculture, and also a member of the Legislative Budget Committee. Whereas Bobby Moody served as Budget Director and later Interim Director of Medicaid in Mississippi, and Bobby Moody, as member of the Board of Health, helped select 2 outstanding state health officers, chaired the Legislative Committee, and was instrumental in overseeing one of the most successful COVID vaccination programs in the nation. And whereas Bobby Moody has continually worked with the Mississippi State Board of Health to improve the quality of life for all Mississippians. Therefore, be it resolved that the members of the Mississippi State Board of Health wish to express our gratitude and respect for Robert Bobby J. Moody and the lasting impact he has made on the health of the residents of the state. Mississippi State Board of Health.
What? Well, if you look good, this is just.
I would love for you to, and I'm going to hold this because it's heavy. All right.
Well, you know, I never had an intention of getting involved in politics. Ann and I had already gone to bed one night, and we had some friends call me and say, look, we a group of us here that we've been talking about trying to get somebody to run for the legislature, and we'd like you to consider. And I said, well, I don't know about that. We're gonna have to think about this. Well, you know, and Ann and I discussed it, and of course, having a special needs son, we felt like that might be an opportunity for us to contribute and make a difference. And we did go ahead and run and was elected. And I came and met with the then Speaker Buddy Newman, and everybody wants to be a member of one of the major money committees. And I asked him about that, and he said, well, called everybody Scalabooger. He said, Scalabooger, I might can accommodate you, but he said, I need somebody that'll get involved in public health and welfare, because that's where the action is going to be for the next few years. And that is where I started out. And, you know, I guess when I became chairman, I felt so intimidated. Dr. Davis, there was doctors sitting there looking at me, nurses, pharmacists, dentists. And I thought, you know, I don't know how I'm going to be able to handle this. And I knew, you know, they were a lot more knowledgeable than I was, but they could not outwork me, you know. And for years, I was first person in the Capitol. A lot of mornings I actually made coffees for the porters before they got there. But, you know, from that is where it all came about. And I guess some of the things that I was most proud of was our vaccination program. And it really hurts me to see it seem like kind of falling by the wayside. And I think we've seen in our nation how some of the things that we're not getting vaccinated for are exploding. And, you know, it just, I guess, gave me as much pleasure as anything else to see some of the things that we had incorporated into our state government for people with disabilities. One of our things that I think I'm most proud of is I heard about a program in Boston, Massachusetts. And I went up there one summer, and it was a job coach program. It's where they can put an individual with someone who has developmental disabilities to work with them up to 6 months to try to help them learn to do a job. And that's where our son went into that program and retired from Walmart after 20 years. So it's one of the most important programs in our state as far as I'm concerned, because it puts them on the tax roll. Instead of them being a burden to the tax roll, they're actually taxpayers. You know, and I was thinking coming down here today, at one time there was one of the news meters that came out with one of the most with the 10 most influential people in state government. I actually made that program, but when I got home to tell Ann about it, she told me, knew how to put me in my place. But you know, of all of the things that I've been able to do, and I've been involved in healthcare in this state for over 40 years, the honor of serving with some of the most dedicated men and women on this board that I've seen that are giving of their time, really just giving of their time to make things a lot better for the people of the state of Mississippi. Tim, I thank you for, you know, if I knew I was going to be on that board, I'd have probably raised our $40 person. But thank y'all so much for this honor and for allowing me to be a part of y'all. And, you know, sitting over here on the side has been my biggest supporter through all of this. Thank you.
Greg? This is the right spot. This work? Appreciate you.
We gonna slip out. We've got a couple of things.
Yes, sir.
We've got to do.
Thank you. We're so glad you're.
Thank y'all.
So we can't get him to vote.
We'd
We'd like
I
to.
probably voted wrong.
Okay.
Thank y'all.
That's all right. Can I get
That was nice. And I appreciate the audience indulging the board with that recognition. What an outstanding man. First item on the agenda is the approval of the minutes. And we've got several sets of subcommittee meetings, which we can approve with the general minutes as well as our general minutes from November. Are there any corrections that anyone would like to make to the minute? If not, I need a motion. Beth, will you give us a motion? All right, and Rick will second. All in favor, say aye. Aye. Any opposed? Excellent. It passes. Dr. Edney, we're looking forward to your presentation.
Look, I just went from the, do we have a
Yes.
CON minutes for the last CON meeting? Or is it, do we have, the CON committee have to approve those minutes before they go to the board?
Well, they go here after, so how the committee minutes work is they're approved by the subcommittee and then come
Be
here.
the chair and then it's referred to.
All right, very good. So you will see those, but just not yet. All right. Dr. Edney, the floor is yours.
Thank you, Mr. Chairman, and thank you, board members. Happy New Year. We are already off to a busy 2026. Hard to believe that we're in another legislative session and we're a weekend and it's been really busy. And I'm proud of why it's busy and because we've been able to get the meetings that we've needed related to the Board of Health and the Department of Health's agenda with our committee chairs so that our legislation is being introduced. But most of it has been related to consultation of our committee chairs on other legislation that's not on our agenda, but impacts public health or is likely to be an assignment towards us. And I appreciate the fact of being involved on the front end of those discussions. But thus far, all those conversations are going well. Before we do EPI report, this is an important time of year to pay attention to what all the bugs are doing out there. I thought I just would quickly review how 2025 went for us here at the department. You know the challenges that we faced in 2025 with DOJ rescissions of 230 million, and then with anticipated budget cuts that may not be quite as severe as it looked 6 months ago, but will still be significant. But probably the biggest challenge that we had administratively was navigating the shutdown, and the federal shutdown was, as you know, the longest one that's occurred thus far. And the challenge was to get through the shutdown without being impacted and also without having furlough of our state employees. And we were able to successfully do that. We had great cooperation with the governor's team, with Liz Welch and her team at DFA, with legislative leadership. This was we were able to make sure that WIC benefits continued. The good thing that has happened now, the continuing resolution adopted a year budget for WIC. So if there is another shutdown, WIC is funded. So we won't have to go through that. WIC was our greatest vulnerability because of the large amount of dollars that we process per week to the vendors in the WIC program. But we were able to navigate that successfully. But that took a lot of cooperation throughout state government. And I am pleased that we did not have to furlough any of our full-time employees. We did, have to reduce some of our contract employees, and but the core of our workforce was maintained without any disruption. Y'all know this time last year we were in a legislative session beginning that wound up being quite successful with all of our agenda being enacted. I'm extremely proud of the fact that the Public Health Trust was enacted, and we have had meetings with the state treasurer's team and, and their review of the statutory language really shows it's exactly what we need. It's interest bearing, it's protected. They have the ability to receive gifts of any type, including, real property, stocks, bonds, and they handle all of that. So they're in the process of establishing the fund, which will act as an endowment. They of course handle all the investments of it, but we have had some good interest from private philanthropy, and as you know, the Public Health Trust seeding it as part of our legislative agenda, and thus far the conversations there have been very favorable. And having community health workers enacted last session was very helpful to us, and we've been working very cooperatively with the Division of Medicaid, and we're currently going through the regulatory steps for the certification process, and the division and we have a good game plan together how to move forward on a good pilot project on the funding of CHWs and the Medicaid program in a way that does not strain their budget at all, which was a big concern of mine. So good partners at the division helping us with that. I will tell you a significant part of the Rural Health Transformation Grant application involved workers at the community health worker level. So I was quite pleased that it was very helpful that we got that passed last year for the RHTP grant, because that was one of the areas of emphasis that CMS had, and we were able to take advantage of that based on last year's agenda. Just reminding you that we successfully achieved reaccreditation in 2025 for the agency, and then achieved initial accreditation with our vital records program, and we make only the 6th state who has an accredited vital records program. So my vital records team, Pat, Brian, so proud of y'all, and I have to work really closely with those two on constituent services, but they do a great job making us look good here at the agency. We have spent really the last quarter deeply involved with the governor's team in developing the application for the Rural Health Transformation grant. And that, Mr. Chairman, that was a very successful grant application. Out of the maximum funding or full funding of $200 million a year, the state of Mississippi was awarded to right at $206 million, which means we got all of ours. And then states that did not receive full funding, all that the difference went back into the pot, and CMS redistributed that. So and we got more than the state of Alabama. So when you look at per capita, we did very well. Some of the other rural states that had more funding than we received were had larger population density than we had. But that money will come to the state, as I understand it, next month, and we will be awaiting our assignments from the governor's office Um, I have a good idea of what most of those assignments will be, but that could change. The governor's office is in charge of the grant and the administration of the grant. As the governor has explained to us, he wants an all-government approach, which assignments will go to the agencies, and the agencies will administer the programs that have been approved in the application. So it will be significant work coming to us, probably more than ARPA, which I know is giving Chris PTSD, but it's extremely important work. And I have characterized it with the description. This is really a moonshot opportunity for rural healthcare. It'll be over $1 billion over the next total over 5 years. And we're just really excited about that opportunity. As part of that, we have been discussing the last 3 years the need for the state health plan to be something more meaningful for state health policy planning. It's the way it's statutorily built. It is basically just a regulatory document for CON, and y'all have voiced very clearly the desire for a component of it to be accumulating, processing, and mapping the data of what we have in the state and how things need to look. The governor has also been very interested in that. And so really the Rural Health Transformation Grant team saw as the number one factor that needed to be done was the statewide comprehensive healthcare assessment. So, which is what we've all been talking about for 3 years. And so now we have the funding to get that done. We issued an RFP for the support that we'll need. That's going to be a heavy lift that we need to do very quickly. But we issued that RFP already, and so we'll have that contract awarded through the RFP process very soon this month, and be able to get that work going as the rest of our HTP is being organized and moving forward. So we'll be initiating that work, which is going to help inform much of what that grant program is going to do otherwise. And the discussions that the governor's office have been, having a planning tool that helps us not only see what we have, but help inform where we need to be going. And that's been the dream and the desire of this board and this agency. And now I see it as an opportunity to come to fruition. We already have separated CON as a regulatory action using the current state health plan away from state health policy and planning. So those are two different areas that work cooperatively in conjunction with licensure as well. But we're keeping CON regulation in its wheelhouse, and then policy and planning flowing out of that with the results of the comprehensive statewide assessment. And then our goal will be to maintain that going forward. I'm certain that as we do the comprehensive healthcare assessment, we will answer many questions, but it will generate more questions. And we'll just need to keep following, that information. And then our desire is to keep that data fresh and, not renewing the data every 3 years, but keeping the planning document, on a much quicker cadence than that. I'd love to get it to where it's every quarter, but certainly no more than annually. That's the purpose of the contract that we're issuing, is to get us where we've been trying to go. Y'all have any questions about that? That's checking off a big box that we've all been working on together. And so we're otherwise with RHTP, we will have a significant assignments out of that, but we're in holding mode until we receive our assignments. I am pleased that in 2025 we did see improved population health outcome metrics. I've shared some of those with you, but this binder for you has all of our annual reports that gives you a hard copy. That includes under Section 4 is our 2025 annual report that is legislatively mandated, but it's, very instructive for us as well. So you have an opportunity to go through the annual report data. The first 3 tabs are our mortality review reports, infant child death review, and maternal mortality. Tab 5 is the new HMA report. I sent that out to y'all electronically, but that was the requested study from the legislature related to CON reform. I have that in your packet. Tab 6 is medical cannabis annual report. I'll talk to you about that in just a second. But let me highlight what I saw as the really strong positives in our population health outcome improvement. Y'all and I had been very concerned about the rate of preventable death in the state. In fact, one of our outcome measures is that we have the highest rate of preventable death in the country, which drives our low life expectancy and is very expensive, as we demonstrated in the financial impact study that we did. But one of the indicators I'm watching in terms of preventable death is the metric that's in the annual report, and that is measuring the potential years of life lost before age 75. And because most of that is preventable death. So 75 is about our life expectancy, which is way too low, but that's what it is. And for every death before age 75, we look at that death date and what's the difference between their age at death versus at age 75. And we literally add those years up for all the deaths in the state for the year. And 3 years ago, it was running a little over 225,000 potential years of life lost. And it has been trending down. And I was really anxious to see that number this year, and it trended down to just under 190,000. So I think it was 189,000 plus. And so those are significant years. And that I anticipate we'll see if that trend continues, as I think it will, we'll see life expectancy start to trend up like we need it to see. So that is an annual indicator that kind of gives us a longer term trajectory way of monitoring the health of the population. We have made strides in maternal death. Those numbers have gone down significantly to where now our real concern is that our mortality review report does not speak to maternal morbidity, because we do have women who are very ill related to their pregnancy, but thankfully survive. But they may still have persistent cardiomyopathy, or they may have had a stroke in pregnancy related to pregnancy-induced hypertension, or they may have had kidney failure in pregnancy. So, and this is a nationwide effort is now to really look at severe morbidity in pregnancy, because that clearly drives our infant mortality numbers. That 50% of our infant deaths are related to preterm low birth weight babies, and we need that oftentimes, not always, but oftentimes is related to an unhealthy pregnancy generating that preterm birth. So as we study severe maternal morbidity, we will be getting more information. We have made no improvement, as you know, with infant mortality. In fact, we went the wrong way. And we'll be talking about that in Dr. Chaney's committee report in just a bit. I was, pleased that in the America's Health Rankings report last year, we did move up. It was the first time we have moved up from 50th on any national health ranking. So I've never been so proud to be 49th in anything, but that, I'm anxious to see what this coming year's shows. But what really encouraged me, we did not move up in the Commonwealth Report rankings, but as I had shared with y'all before, we improved in 19 of different health metrics, which was more than any other state improved. So it shows we're moving in the right direction at a population level. We still have a lot of work to do. Certainly, not a whole lot to brag about, but it is, you know, I am far more optimistic than I was 3 years ago in terms of the trajectory of the health of the population. And we will continue keeping that as a top tier issue. I did want to point out, Mr. Perry, the medical cannabis report, you know, we are required to issue that in combination with Department of Revenue at year's end, and that report goes to the governor. The program continues to mature, and it is being well regulated. It's being efficiently run, and we are, you know, a tight regulator in this program. But I think we're in a good spot with our regulatory work. Industry is responding to our regulatory actions appropriately, and the program is maturing in patient count. We went, I think, from 49,000 to 65,000-ish patients in the program. Tax revenue has gone up, significantly. We are seeing free market forces where, some licensees are no longer to stay in business, but we are seeing growth in the workforce in the cannabis industry. The work permit numbers have gone up significantly. The net revenue off the cannabis program for the state last year was just over $12 million, and that's been a steady increase. So I do remind our friends at the Capitol of that, because we're responsible for about 80% of the regulatory action that's generating that revenue for the state. And then I had for you under tab 7, just for your use, and this was a multi-program effort with the Center for Rural Health and Dr. Young's team. Sam, I think I saw Sam Miller was up late the last 2 nights generating these maps for you. And this is really helpful for our CON work, but it's going to be helpful for all of our work as we are really able to delineate nicely what our non-rural counties are, our rural counties, and then our really rural counties, the super rural counties. And so now we've got that under tab 7. And that was actually a heavier lift than I expected, because every federal agency had different definitions, and the team just kind of melded all of the definitions from HRSA and CMS and USDA, and I forget who else, but the final product of using everyone's the metrics the different federal agencies are measuring, I thought came up with a map of our counties that made a lot of sense, and I think will be very helpful in our work going forward. It definitely will be helpful for the CON committee's work. So, Ms. Chairman, a lot of challenges in 2025, but really, as I was reflecting, those challenges really helped us strive to be better and helped us see some opportunities for efficiency improvement. And oftentimes that's what we see is in times of, I don't want to say crisis, definitely crises are very instructive, but when we're facing challenges, we learn a lot, and we are able to see where we can be better and try to be better. So despite the challenges that y'all worked with us through in 2025, lots of success. And I think we're in a good place in terms of public health in the state, and we continue to move forward in 2026 in like fashion. And any questions before we do the EPI report?
I do think those maps of rural areas are going to be exceptionally helpful, not only to us, but the legislature, and they really show some holes in the delivery of dialysis and psychiatric care in the state.
Yes. All right.
It also helps you better understand some of the issues that we have with systems of care in the state.
Dawson.
I thought if I hid behind the column,
No, most excellent.
I forget. But good morning. It's good to be. So the epidemiological trends in Mississippi for the week one, ending January 10th. Wow, only 1 week. I know a lot of people feel like it's been 2 to 3 months, but only 1 week. So what we're seeing from our Sentinel providers, and that's our providers out in the field who provide us with data on the patients that they are seeing. ILI here stands for influenza-like illnesses. So the rate that was reported for that first week is 3.7%. That is decreased from 4.9% in week 53, so at the end of last year. And it is lower than it was this time last year, 6.2%. So far we're winning. As far as the syndromic surveillance data, this is data that is compiled by the CDC. And we get BioSense as their platform for syndromic data. So in that realm, our influenza-like illness rate is 2.2%. And that is also decreased from week 53, where it was 3.7%. The COVID-like illness rate was 0.8%, and it is decreased from 1.4% in the final week of 2025. And the RSV-like illness deaths were at 0.28%, and that is also down from the week before at 0.39%. When we look at the wastewater data, the surveillance data, we get this information from the CDC as well. What we're seeing in the wastewater is influenza A, and it's based on activity. So there's a certain level, and the influenza rate is 6.57 points above the standard deviation. So we're seeing that much more of above what we think is normal. However, that's decreased from the week before, where it was 7.67 points of activity above the standard deviation. In COVID, at this point, we're seeing 9.97 activity, and that is increased from 3.05 in the ending week of 2025. So that's a significant increase. And then RSV, I always want to RSVP. I'm looking for the next party, I guess. But in RSV, it's 2.96 above the standard deviation, and that is decreased from 6.11 in week 2. So overall, the trends look very good for us here. Any questions?
Do you have the pertussis data from closeout?
Sure, yes. At the end of 2025, we closed out with a provisional number of 144 cases of pertussis. The age range for those cases were between 7 to 77 years, with the median age being 5 years. And we had 17% of those, or 24 hospitalizations during that time. The median age for those hospitalized was 2.5 months. And sadly, we did report one pediatric death in the year 2025, and that was in a patient who was less than 30 years.
The rest of the country's having a pretty significant flu outbreak, right? Or are they?
It appears that way, but from the evidence we have from CDC that's compiled from all of our area, we're not.
We're doing relatively well there.
Yeah.
What about measles?
We have not reported a case of, we have not diagnosed a case of measles in Mississippi, even with all of the outbreaks around us. We've had the states around us, Tennessee, Alabama, Louisiana, all have reported cases, but we have not diagnosed a case here.
What other questions do we have?
On the flu vaccine, regarding flu, I keep hearing from the public that this year's flu vaccine just isn't any good. Do we have any data on that scientifically?
We don't have any scientific data to show that, but our numbers show that we have decreased activities though. And the wastewater information is suggesting that it's all melding together. So I think I'm gonna reserve judgment.
Yes, Dr. Waits, what you're reading is the strain that was identified late in the Southern Hemisphere. It came forward in the Southern Hemisphere after the decision for the formula for the flu shot had already been decided upon, so it didn't make it into this year. And that's not an infrequent occurrence. You know, they're watching the Southern Hemisphere strains to develop, you know, the Northern Hemisphere vaccines. And some years they hit it right on, and some years they don't. It was one of the 4 strains in the vaccine that didn't match. But still, you know, the vaccine itself, as you know, will generate, you know, more immune protection, even for that strain that's not covered and without vaccination. And one thing that disturbed me a little bit in the media reports is they're using the term super flu, which y'all super flu for us is a whole different ballgame. That's 1918. You know, and we're not looking at a super flu. They're talking about that one strain that was identified late, and it is a virulent strain, so it does cause, you know, significant illness. But as we're looking at those hospitalized patients, you know, Dr. Carlton, I'm sure y'all were seeing in the ER, but the vaccinated folks just aren't as sick.
This is the H3N2K strain.
So and it's interesting, Louisiana is a very high impact state, and we're much lower. Our rates of flu are much lower than across the river. So right now we're doing okay. It's, you know, it's been a busy flu season, but I'm hoping it's time for that first wave to be coming down, is it not, Dr. Dotson? As you're seeing, we're getting close to being through the worst of it. The hospitals have been busy. I've had some calls about difficulty with transfers, but nothing like the last 2 winters have been. Hospitals seem to be doing well thus far.
Dr. Dodson, what are we seeing with COVID? It's still out there. Is the morbidity less significant this season? Do we anticipate another upsurge of COVID over the next few months?
Our information mostly about COVID is anecdotal because it's no longer reported oral illness to us now. So we only get bits and pieces of that. So we don't have the entire picture of that data. We can see what's happening in wastewater, and that does suggest that there is starting to be a little bump of COVID coming on for us. But as far as what is presented to us, those are not reportable cases anymore. Pediatric deaths are reported to us with COVID and pregnant women is reportable to us. But the overall positive test for COVID is no longer reported.
The wastewater surveillance is really helpful, and it's now one of our strongest tools in public health surveillance that we have, and we're growing out that capacity even better. We do still monitor genetic variation. We have partners that send in samples that we're able to test which strains. So we're able to monitor flu and COVID that way, and COVID just is kind of doing its thing. It's not really shifting, thankfully. You know, main concern is flu. Flu is much more virulent for us right now than COVID is.
What other questions for Dr. Dodson? All right, thank you.
Thank you.
Keep up your good work.
And Ms. Chairman, Logan, we'll defer that action item to Mr. Hubbard's committee just a bit, but that concludes our report. Thank you.
The next item on the agenda would be, so we're going to defer Logan's presentation to later. So we'll go to the Chief Financial Officer's report. Ms. Tribune.
Good morning.
Good morning.
This morning, I want to give a brief update because of the current phase that we're in the budget process. I want to touch briefly on the overall agency's recommendation and the medical cannabis recommendation. The agency's total budget request for FY 27 is at 594 million. As you probably mentioned from last board meeting in October, that we mentioned it and that we're remaining level with the FY 26 budget. The FY 27 budget for medical cannabis also remained level with the FY 26 budget of 7.787 million. The Legislative Budget Office has released their recommendations, and the recommendations for FY 27 for the agency is a total of 585 million, and for cannabis is remaining level at 7.787 million. The agency, we do have our budget hearing tomorrow on the House side. So hopefully after that, we can get closer to an actual our budget for FY 27. And after that, we can are there any questions at this time with us being in this phase of the process?
Talk about how are we doing with the construction?
Okay.
Would this be the place to bring that up?
Okay.
It'd be perfect. Mr. Tribune oversees that.
The pharmacy warehouse, we should be getting ready to have it released back over to us within the next month or so. I know the projected timeline for finishing has been pushed back. There was a little issue, but they're working on it. The contractors, they have been steadily working to complete that. So I'm asking and hopefully pushing for the next board meeting where we can sign up and have you all have a walkthrough and a tour of the building. But we're just waiting for it to be released over to us.
We really thought we would be able to go in today, but it's not ready. And also update the board regarding the other Underwood renovations.
Okay. Actually, the next phase of the project, if you recall, it was the pharmacy warehouse was the first part, and then they're going into the next phase. One be starting on the Underwood building, which is directly in front of that area that they were working on with the pharmacy. We will be meeting with architects on Friday to get started and push forward with it. We do have the funds already over there, and so BFA called and they're ready to get started on the next phase of it. So we will be meeting on Friday to get that started and seeing when we'll be able to break ground with that.
All right. Excellent.
And Mr. Tribune has a good game plan for us to really be much more aggressive with preventive maintenance of this building. And this is really demonstrating a lot of problems here lately, but I'm optimistic we'll be able to do a better job maintaining this building.
Yes.
Will renovations of the Underwood building allow us to bring some offices back here to this site, or what are our plans with the Underwood renovation?
There are several phases to that because of the condition of the building and the size of the building, and also we're looking at funding. And so depending on our funding and if we can continue with the projects, I can see that there will be some space there to bring staff more central instead of having housed outside of the center campus. But we really have to look at the space utilization that we have now and bring those empty spaces back online to see what's the best way to bring the office back. But there is potential there to bring some back onto the center. And I know Dr. Ed, he has been really advocating for that. So we are hopefully, once we get started on the building, we can continue in the different phases to open up that more space.
You know, we will be bringing all the pharmacy staff from Lawson Street, which if you've never been out to where our pharmacy is now, don't bother. We need them here. That is definitely not really need to be. That structure is more than outlived its life expectancy. And if you've not gone through the Underwood building, we really need you to take a peek at it where it is now, so you'll appreciate where we're moving. That is a historic building. It's where Dr. Underwood's office, was, and it was the original Board of Health. If you look at how that building is named, it's the Board of Health building. So that predates the agency. And it's also the original public health lab that faces North State Street. So we do want to do it appropriately, but we desperately need that square footage. And right now, I mean, our folks are just being very patient with the condition of that building. We have varmints and everything else, water coming in, snakes, and all that is going to be brought back to full life in a good, healthy way. So I'm excited about
The
that.
varmints are over at the Underwood building?
They are.
Oh.
We have some varmints in this building, but but also we're studying, working with DFA. We have folks, we have a lot of employees at, off-site, and we're looking at what state buildings are available. And we're having to pay leases at these other properties and looking at state buildings that are available for our workforce to come in more centralized in state buildings. We're working with DFA through that process. No decisions have been made. And we will take possession of the women's club, hopefully soon. That building will need some interior work done, but that'll be more square footage for us.
And that's a beautiful building.
It is. Yes, sir.
What about the the public health lab, the repairs that were going to be done there? Are they done?
No, they haven't started yet. I met with the architect on yesterday. We are waiting for they're gonna give us a 2-week lead time as to when they're coming in, but it is in progress. It's really just waiting on architects to go ahead on and move forward. And then also that same type of project, the envelope project for the lab, we still have an envelope project for this building as well to correct the issue, the same type of issue with the windows. And we have not met as far as when this week will get started. So it's the pharmacy warehouse, the Underwood, the 1B phase, and the lab. So all of that's going on at the same time currently right now.
And we're going to keep our focus on this building.
Yes. The only thing I can say that we have completed is the garage elevators. So everything else is just a work in progress, but we are staying and working with DFA, Bureau of Buildings, and we are making progress on it.
And maybe April, we can plan to tour it as a board.
Yeah.
And we might be able to see some of the Underwood building minus the varmints during that tour as well. All right, excellent. Thank you. Any other questions?
Okay.
Appreciate your good work.
Thank you.
Dr. Edney, what else do we need to talk about?
That is all, sir.
Thank you for an excellent report. Any other questions for Dr. Edney before we go on to our agenda? If not, the first item on our agenda is the consent agenda. There are several items, 4 items under there. One is proposed regulations governing the OB system of care, and these are new rules developed for the OB system of care. Public comments have been received and modifications have been included, which included anesthesiologists and nurse anesthetists based on public comments. Also, number 2, the proposed amendments to the regulations governing planning and resource development, TON. There was a correction of an administrative error within that. Also, number 3 has a proposed amendment for regulations governing the minimum standards of operation of Risky Hospital. This was just an alignment of state standards with federal regulations for emergency preparedness. And number 4, the proposed amendments to the regulations governing licensure of child care facilities. Public comments were received and review by Child Care Advisory Committee was completed on November 21st. With approval, with one change reflected, was given by the Child Care Advisory Committee. So these are 4 items. Do we want to extract any for more comment?
Just a little bit more on the childcare. What's the substance of the childcare? I'm not asking to extract it.
Yeah, so these are the ones that we pulled from the last agenda because we didn't have complete advisory council review. But this is basically adopting federal regulation changes that we're required to do to be in compliance with that federal grant. So nothing outside of what the federal guidelines were requiring, and the advisory council did adopt it.
As far as the OB system of care, I know that's something we're very excited about. You have any comments about that?
Those are not changing. We will talk about it in his committee report.
Very good. All right. So even though there's a lot here, it doesn't look like there's anything, it should be a problem. Is there a motion to approve the consent agenda, which would be items 1 through 4? There's a motion and there's a second. Any further discussion? All in favor, say aye. Any opposed? All right. Very good. Dr. Cheney, I hear I can feel your excitement about the new rules for OB system care. It is a historic vote you just made. The next item on the agenda is committee reports. And why don't we start with you and with the maternal infant report from your committee.
Certainly. Yeah, that's really exciting because there's been a tremendous amount of work and which I don't completely understand, but there are a lot of people I think that are going to need to be thanked for their work. But you know, as you remember, the impetus behind the OB system of care, and as a subcommittee that has the development and approval of our part of the OB system of care has taken all of our work, and also I'd like to thank the subcommittee members for the time and effort spent on that. But the impetus was just our maternal and infant outcomes. Something has to be done, and based on the recommendation of just historically based on the recommendation of our state health officer, the subcommittee initiated that process that has resulted in the OB system of care plan. And certainly, anytime you try to thank people, there's always a risk of not thanking everybody. But I certainly know that Teresa Wyndham and her Department of Acute Care Systems has done a tremendous amount of work. And segue into there's been so much work. Who all do we really need to make sure?
I want to let the board know my expectation for this meeting for Teresa and her team. And Teresa, I'm so proud because Teresa's team is working with all of our other teams that are working with maternal infant mortality. My goal was to have the maternal and neonatal level designated levels of care for y'all today. They got the whole thing done. I mean, we're complete. That was 140 pages of regulation that the non-committee members need to thank the committee members because they're the ones who plowed through all that with us. That's where the committee system works is, that the committee worked with us on all that detailed regulation. And so you're not having to consume that today. But I was just extremely proud that we have the entire system of care built. And now we have a 30-day mandated wait period for final comment. During that 30 days, we're going to be pre-positioning ourselves to be ready to go 30 days from now, and begin with our working with our hospital partners with their designated levels of care and constructing the system that y'all have approved today. Dr. Cheney and I, did want to recognize I thought we would go ahead and just let you see everyone who is working in this space within the agency, because with infant mortality struggles. We have taken an all agency, all hands on deck approach that's proven to be effective. But Teresa, won't you and your team, Christy and Teresa, introduce your team?
Well, I know, Christy Baird, that's the deputy director. John Wright is, well, he'll be working with data. And then Tina Rawls is kind of our project manager that keeps us all going in the right direction. But very proud that they are the ones, they'll stand up. They are the ones that did the big work. And then I do want to recognize Dr. Henderson because he has been very instrumental in helping us and working with us on those rules and regs. And then Dr. Morris is also, she would think.
So this is a group of overachievers. Well done. Thank you.
Thank you.
Recent team are the acute care team, and they have systems of care. So they have to deal with the trauma system, stroke and STEMI, and now they have the high-risk perinatal OB system of care to deal with. I do want to thank Dr. Randy Henderson, who not only is stepping up to help us. Randy is a neonatologist. He's overseeing and leading our neonatal levels of care effort, but he also chairs child death review and volunteered to help us this last year with developing infant mortality reviews. So Randy is a glutton for punishment, but he has been invaluable as subject matter expertise for us. And Randy, very grateful. You have worked extremely hard with us on all of these projects, and it's a passion project for Randy. We are grateful for Dr. Rachel Morris at UMC, maternal fetal medicine expert, who is working with us on the maternal side. All right.
Point out that Dr. Henderson is from the Hattiesburg Clinic and had the good fortune to marry Anita Henderson from the Hattiesburg Clinic.
Sister Perry has a question.
I mean, I'm embarrassed to ask this question considering we just voted. For those that aren't on the committee, what did we just approve? I mean, what that which we're celebrating? Could you give us the?
Yeah. All right. So this sets the plan for the OB system of care, and it's very, very detailed, and it sets out what's going to be done on the OB side, on the pediatric side, and the rules and regs for how to run that system.
And it's
Very detailed.
And the problem that we're solving is what?
Yeah, our maternal and infant outcomes to try to get improvement. And there have been some really good efforts in the past that never were sustained. But my understanding of the kind of big picture is this is the first time in history we've actually had everybody trying to work together. You know,
So for the members of the media that are here, they're trying to figure out what story they're writing. What is the story they're writing? We trust it. What is it that we've done to try to improve outcomes?
To develop this system of care, which will be transformational in terms of having the hospitals all on the same page of music, patient movement between the different levels of care, and yeah,
High-risk mothers that are having difficulty with their pregnancy are not going to sit in an emergency room where they don't need to be. They're going to be sent immediately to trained professionals that can deal with both the mother and the child.
So with these new standards and processes and systems, that if somebody is that may have been more at risk of having a death before, now it's to get the paperwork out of the way so that we know we can get them to the best care possible as quickly as possible.
And it's not just the end point, which is really important, but also just the prenatal care piece is part of the.
And think of our other systems of care. I mean, we've been pioneers with our trauma system of care, which you're looking at what is it, the magic hour, what do they call it? The golden hour. Where positive outcomes can occur if you can get somebody to the right person and take action. But our trauma system of care, we've got a heart attack system of care at STEMI, and then a stroke system of care with hopes that those are situations where you don't need hurdles in getting the patient to the right setting as quickly as possible. And I think that's what we're hopeful with the OB system of care, and we've developed something that can get a problem pregnancy that's having an issue that can get immediately to the right setting and thus decrease maternal morbidity and mortality.
So, given the statistics that Dr. Edney walked through this and the actions that you and the committee and great members of the department have done to try to address some of this, and the fact that there's some people over here that have been very focused on maternal and infant mortality issues, I assume that there's a layperson's description of what's going on that the department communications team is going to send out to.
Yes, sir.
And for people who don't, for the layperson doesn't know what a system of care is.
And as I've talked about a lot, we don't have bad OBs, bad hospitals, bad nurses, or bad patients. They might be unhealthy, but they're not bad. We have a bad system or a lack of a system. What we have organically, and that was true in trauma until we had a couple of governors almost dying car wrecks. And now we have a system overlay statewide so that, patients now go to the right level of care based on injury rather than the closest hospital. What we have now is no system at all, and very high-risk women delivering preterm low birth weight babies are going to a lower level birthing hospital, and then we're having to move that 27-weeker or that 29-weeker somewhere, and it doesn't happen very quickly right now. So the system will do a few things. Number one, it will it's managing this comprehensively statewide. It will have a dedicated, designated level of care for each birthing hospital and their NICUs. And that will be us, just like we do the trauma hospitals. We will designate the levels of care, and that will inform where levels of risk should be delivering. But understanding things happen, babies come when they come, that if we know that we have a high-risk baby being born at a lower level, the system is activated. We can go ahead and get transport moving to go get that baby. And then the system, meaning us, will be making sure that we know where the beds are, we know where that baby needs to be, and the system will get that baby moved instead of everybody calling each other.
Trying to figure out ad hoc every time.
Exactly. And so there's more of a system to, number one, hopefully high-risk moms will deliver at the right level of care where she has everything she needs and the baby does. But y'all, we have about 35 births per year in ERs of non-birthing hospitals. So that's another group that the system will expedite moving that mom and baby to where they need to go. We have not had that ability to expedite things until the vote that you just made. So, Mr. Perry, the headline is Mississippi State Board of Health enacts in a historic fashion the state's fourth statewide system of care.
Well, I think you should take out the board part. It's probably worthwhile rather than Pat.
And what's really exciting to me is we will be the only state that I can tell that is doing it comprehensively. A lot of states do the maternal levels and neonatal levels and try to risk stratify things. But when it matures, Teresa's job is to get us to where it activates with 911. Because being in a very rural state, we're having obstetrical emergencies in the field, and we need to activate the system with women who are bleeding in the field and getting them to the right level of care, getting them the care they need immediately, which just historically has not happened. But what Dr. Cheney's point, the reason it's been tried, this has been attempted twice, and not a true system of care, but perinatal regionalization has been attempted twice and never got across the finish line. The difference now is everybody agreeing to the problem that we're facing And it's gonna take all of us and everybody coming to the table for the first time. And that was really the first year of work, was getting that to occur. Once we got that, everything else started falling into place. But, you know, when you're 50th and something, I think it's okay to do things that other folks aren't doing. So no one is doing it as comprehensively as Mississippi will be doing. And a lot of folks are paying attention to how we're doing it. And the reason I really thought this is how we needed to go was based off our history with trauma, STEMI, and stroke. That those systems worked. And so, and we're good at it, you know, as a state. It's one of the things that we're really good at. So we have other things to do, but this is kind of the centerpiece of our efforts. And it's been 3 years in the making, and it'll be, Randy, a few years of maturing, but we've got the right people to get to work. Then, Mr. Chairman, also with Tanya, stand with your team. Tanya's team, Krista, Bernicia, this team is doing the maternal infant specific work with Healthy Moms, Healthy Babies, our cribs program. They are doing the town halls that have been very instructive. We're hearing a lot of good information from the town halls that they're doing. And I know I'm leaving something out, but Tanya, introduce your team.
Okay, Krista Wines is the director of our Office of Perinatal and Infant Services. Works Dr. Bernicia Wilson, who manages our Healthy Start program. She's also facilitating the community town hall listening sessions, which you said have been extremely informative. As a team, we absolutely believe that the problems belong to the communities, and so do the solutions. That's where we're gonna find the answers. So we're working very hard on that. Krista works and leads Claire Mazingo in administering our Cribs for Kids program, making sure our goal is that not another infant in Mississippi dies in an unsafe sleep situation because they don't have access to a crib. So that's, again, extremely important. And then I have Stephanie Smith here, who worked with Drs. Henderson and Brooks on our, which the whole team worked on our child and infant and maternal mortality reports and reviews.
And I'll add that Dr. Chelsea Watts is a pharmacist by trade and training with the agency, but she helps to lead administratively the Healthy Moms, Healthy Babies program.
Great, thank y'all. Good, great job. Yeah, see, Tammy Brooks is our medical director, so she has to work on all these projects. Did we have another team? Sam Miller, Sam stand up. Sam is our go-to guy for all the data and heat maps and helps point us in the right direction. But you can, Dr. Dotson. Dr. Dotson's team in field services, she just sent me executive summary on our closing the OB desert using the county health department game plan. So she has responsibility in that space. So you can see in terms of maternal infant mortality work, comprehensive work throughout the agency. I'm very grateful for this team that's getting it done.
Dr. Edney, what role do you see the community health workers in the new funding that we're about to receive for rural health improvement on the OB or perinatal front? Obviously, this system, if it mirrors and performs like the STEMI and stroke and trauma have, it's going to have a major impact. But as we all know, getting to these moms early in pregnancy and engaging them early in pregnancy offers the opportunity to prevent some 911 calls, maybe. Do you see that being a component on the front end of this overall effort to improve these numbers?
Yes, sir, I do. And a lot of the town hall listening sessions are really reinforcing that and what communities are saying their need. The biggest thing, Dr. Davis, is our Healthy Moms, Healthy Babies program is our home visitation program for high-risk moms and babies. It was a nurse visitation model, which just financially is not sustainable. But we are rebuilding the model based off CHW home visitation. So the nurses have a harder time getting in homes because these are health department nurses and sometimes they're confused to be CPS that we've had trouble accessing. CHWs are embraced much more freely in the community. So and they're lower cost and high expertise in this area. So we're going to be using CHWs for our home visitation model. And then the community education piece on the prenatal side, which is huge, so that we can help women identify what risk factors mean, how not to be high risk when you become pregnant, and if you are pregnant and you're not in care, getting them in care. And then also, I expect them to be really powerful tools with Dr. Dobson's work in the county health departments in general, with our field service work, but specifically in the OB desert work. So yes, sir, you're thinking right along the way we are.
I mean, all of us think that a second headline could read that there's a whole lot more happening in the health department to improve these numbers that are upsetting to all of us outside of the system of care that we just voted to establish as well.
I think the upside is that John and I are trying to do the job of the media.
But if you're gonna do that, I'll tell you about too. You know, each one of these systems of care require standardization of approaches and coordination of all the components in the delivery of care for that particular entity, disease process or whatever. They have all got nuances. And of course, one of the nuances with this one is it is going to be more community-based instead of where the others involve, like injury prevention perhaps. But, trying to address something once it occurs via EMS and the emergency department, this is going to be more driven by the community health workers, by prenatal care and those types of things. But then once you get past that, there's a process in place to deliver care to get the patient to the closest appropriate hospital in the shortest amount of time.
And then the other piece that is very powerful, Dr. Waits is an expert in, is the performance improvement piece. So the system allows us to monitor certain metrics and to measure those, and then to work with the hospitals and EMS providers where we see folks falling out of the curve and where performance needs to improve, and we're able to see those who are setting the standard and those who aren't quite there. And the other systems do that, we help the hospitals see where more improvement is needed. So that PI piece is extremely important.
And unless some other state has slipped in, we're still the only state in the nation that has trauma, STEMI, stroke, and now OB.
Yes, sir.
Like, for example, Georgia has it for a lot of the state, but Atlanta has their own program and so forth. So we're the only one that covers the entire state in all of these areas.
Yes, sir.
I think one of the things too, certainly the regulatory burden on providers and institutions is great. And in the design of this, I do not see it increasing that. There's enough of a regulatory burden already, and I don't see that.
You're not seeing any pushback from the stakeholders with this.
And this is not a punitive system. It's educational, and then using our resources and authority to help patients move the way they need to move. But that's punitive built into it, all education.
Well, it underscores that systems of care and coordination of care are critically important in a rural state that has healthcare holes and deficiencies. And it's a very good strategy to approach it and approaching our rural health system.
Yes, sir.
What other questions do we have for Dr. Cheney?
I was just going to say that the biggest win of this new system of care is more healthy outcomes with moms and babies. The morbidity rate is decreased.
Well said.
Yeah.
All right. Thank you, Dr. Cheney, and thank everyone that was involved in this, Dr. Henderson. All right, next item on the agenda is a committee report from the Legislative Committee. Mr. Hubbard.
Yes, sir.
Logan, you want to help us with this?
Thank you, Mr. Chairman.
Hey.
I have one item for you this morning. This is just a request for a fee increase for the Division of On-Site Wastewater. This fee has not been increased since 2016. And currently we have a $2.5 million deficit that requires general funds to fill that gap. And we're requesting, that's the current and then the proposed, and the wastewater advisory committee voted in favor of this. And the way we've structured it is it will be 3 increases between 26 and 28.
So there will be more than one,
Yes, sir.
which might help us stay ahead of the curve.
This is the final target, that 33% the first year, then another 33%, and the final will be the third year.
Mr. Hubbard.
One thing I want to suggest that we consider is in the legislation, ask for approval to have annual increases based on inflationary factor so that we don't fall behind. We know it's continuing to increase. So I think the board should consider that as well.
Who is the wastewater advisory? Who's the wastewater advisory? You name everybody. I mean, it's like in context, like, are they people who run wastewater systems? I mean, like, who's?
Yeah, it's a board appointed by the legislature. I know folks are on there.
Stakeholders.
So people who are paying the fee.
Yes, sir.
Yeah.
That's right.
And this was brought to my attention after our last meeting, when we set the legislative agenda. Y'all had approved asking for the food protection fees to be adjusted, and we do have support from the Restaurant Association there, and they requested a 3-year phase in, and so we basically mirroring that to just make it easier. But to Mr. Hubbard's point, you know, we don't need to be waiting 10 years to adjust fees and having to make these big jumps. We need to be on the schedule. It'd be nice if they would just allow the board to adjust them in an inflationary manner, but at least us making sure every 3 years that we're taking fees in a rotation so that we keep up with it. But I felt it would be poor financial stewardship to let this $2.5 million deficit hit us this year if we could avoid it. And thus far, the conversation, and I've visited with Dr. Lampton and Mr. Hubbard, the conversation with leadership is positive. They understand we need to close this gap.
The inflationary factor, the president set for that through in the CON statute.
Yes,
on CapEx. They've done that in the past.
It did turn us down the last 2 years, but we keep trying.
Well, this is, I'll add, all of our bills currently, the other bills have their sponsors, and they're just in drafting right now. We'll have those over the next week or so. We've already got a couple back.
And our board has always wanted the fees from a program, if they're supposed to support a program within our agency, the fees need to do that. And the fees haven't been doing that in this case. So this is an attempt to have the program support itself as it's supposed to do. The wastewater, I was thinking we appointed the wastewater advisory committee. Is that a legislative appointment?
I believe it was constituted by the legislature, and then
But you know, most all of our programs have a legislatively mandated advisory council to it, and we take everything through them. They're all different, so I'd have to double check. They're all made up of stakeholders.
My question was driven more about
Stakeholders.
when it said the wastewater advisory committee recommended the fee. I was just curious if they.
Right, that was not Bill and Liz.
Yeah.
That,
This board used to talk a lot more about wastewater and septic tanks, and I'm kind of glad we don't talk about it. That was 20 years ago.
Mr. Hubbard we'll need a motion.
I make a motion that we approve this increase and add a request for an annual inflationary factor.
Is there a second?
Second.
All right, any further discussion? All in favor, say aye. Any opposed? All right, excellent. Thank you. Mr. Hubbard, anything else from the legislative committee? Should be an interesting session. Okay.
They all
All right, the next committee is the CON committee, which I chair, but I'm gonna ask Mr. Perry to present the conclusions from the last CON committee. And Mr. Perry, if you would make the presentation, that would make me happy.
Sure. On Wednesday, January 7th, the Certificate of Need Committee of the board met to discuss potential recommendations to the legislature regarding CON statutes. To inform the committee's deliberations, the committee meetings were held throughout 2025. Hear from stakeholders, including dialysis providers, hospital administrators, and physicians. This built on the work of the committee and the board since April 2023. Many of the board members are the same when we adopted our vision statement for the modernization of the state health plan, which spoke to what Dr. Edney was talking about of having a CON plan and a state health plan. In particular, the committee studied the issues that the legislature asked the department to examine in House Bill 569 of the 2025 session. Though the legislation was vetoed by Governor Reeves over a different provision, the governor made clear in his veto message that he supported the other aspects of the bill, including the provisions which would have required the department to review and make recommendations regarding three things. One, the feasibility of exempting small hospitals for the CON requirement for dialysis units with the goal of reducing the number of transfers of patients requiring dialysis. Two, the feasibility of exempting small hospitals from the requirement for a CON to operate geriatric psychiatric units. And three, the feasibility of a new requirement that acute adult psychiatric units treat a certain percentage of uninsured patients or pay a periodic fee in lieu thereof. Even though this legislation was vetoed, we embarked upon that study at the request of the various committee chairmen and the expectation that that was going to be a requirement. And matter of fact, I think the House actually passed out of committee that requirement the other day. To complement the information we received from interested parties presented to the committee, Health Management Associates also provide a report on these topics. That report has been provided to the board in this binder. So after much deliberation and discussion, the committee unanimously recommended to the full board the following. One, to continue our board's previously adopted proposals to amend the state code to statutorily exempt certain high statewide need areas from the CON process. The intent of this is to remove what can be a costly and time-consuming hurdle for healthcare investments in high-priority areas, specifically psychiatric residential treatment facilities, substance use disorder services, and perinatal services, maternal and infant care. We also voted to recommend to the legislature to eliminate the capital expenditure limits for CON. With regards to the areas that House Bill 569 asked us to look at, after examining the feasibility of exempting small hospitals from the CON process for dialysis and for geriatric psychiatric facilities, the committee recommends that any licensed acute care 24/7 hospital which holds a CON be exempt from the CON requirements for new services. This addresses not just the topics specifically raised by the legislature for dialysis and geriatric psychiatric care, but we suggest expanding the scope to all services, as the committee believes that a broader statutory change can both improve access to care and help sustain the state's healthcare infrastructure. The CON exemption would not apply to services for which there is a general CON moratorium, i.e. skilled nursing facilities, hospice, and home health services. We believe the exemption should be limited to facilities in rural, medically underserved areas, and would only apply to services provided in the facility's existing geographic footprint. This is an approach which the committee examined in 2023 and raised to the board in January 2024 as an approach to ease the burden of both the acute care hospital providers in rural medically underserved areas which face financial challenges, and for the patients in those areas who depend upon those facilities for access to care. The committee acknowledged that additional work would be needed in defining rural. Dr. Edney and team have tried to help do that with the maps that are in our binder. The committee asked the department staff to prepare alternatives for the board, which they've done. Committee also suggests the department staff could work with the legislature in crafting statutory language in line with this proposal. That's our report. I do, what we did not discuss as a committee is how to define the geographic limit as well. I would suggest that we would work with the legislature to craft that. My bias, and it's not, I want to separate what the committee said, but I'm saying would be that you would have a mile limitation to the hospital's location for its main campus, but it would need to stay within the county. If you look at the map that the department provided, there's a number of rural facilities, 24/7 acute care facilities that are right on the county line. And the intent of this is to help patients and to also help these rural facilities that are struggling financially, operating on a tight margin. It would sort of pervert that intent if we allowed a rural hospital to open up operations in the back door of another rural hospital that's also similarly struggling. So if you keep that within the existing county or within a mileage limitation, it could keep them from operating, just going to the other side of the county and opening up right next to a competing, all of a sudden becoming competing rural facility.
And Mr. Hubbard had mentioned in our discussions about the importance of guardrails such as that would be, the legislature would need to be thinking of guardrails to protect institutions and unintended consequences.
And this would not apply to rural emergency hospitals either, because they don't provide 24/7 acute care. Is that correct?
Correct. I mean, as a matter of fact, if you're going to be a rural emergency hospital, you can't actually provide certain services and maintain that designation and get the extra reimbursement. So this is really for the those 24/7 acute care hospitals that are operating, presumably a lot of loss leaders to maintain, you know, a basic healthcare infrastructure in rural areas, to make it easier for them to. They say that they see an opportunity, and we heard some examples over the last couple of years of a couple of hospitals that said they wanted to expand services into an area, and then they looked at the cost and time and potential challenges from providers several counties away. You know, we want to remove that burden. I think that the committee universally acknowledged that this is not going to be a panacea for all things. I mean, you have everything from workforce challenges to reimbursement challenges to from reimbursement both from government and commercial payers. And there's a lot of other challenges out there, but if we can make it just a little bit easier, and even if there's only 3, 4, or 5 hospitals in the years to come that do this, and it helps make those hospitals more financially sustainable and expand access to care, it's worth it. And then on several of these, we've talked about, as the reports over the last couple of years have demonstrated, we're going to approve the CON applications. I mean, some of these are approving it at near 100% rate. So why aren't we spending staff time and resources, and then also spending limited resources of the providers to pay to go through that process? It's just not a efficient use of the scarce healthcare dollar. So that's the finished report. There's other people want to chime in here who sat in the many meetings that Dr. Lambton called over the last couple of years. Please chime in. I think Dr. Lambton's just trying to juice his per diem. It's kind of good. So that.
Excellent presentation. Yes, Dr. Davis.
I mean, my vote, the upcoming vote will reflect my support of the material coming out of the committee. But I think that unnecessary transfers from small rural hospitals are a problem, not only for the small rural hospitals that miss out on that revenue and taking care of patients that they're more than capable of taking care of, but it causes a huge problem at hospitals where these patients are transferred. I got what has turned out to be a very timely text from a good friend of mine who works in a a large hospital in the 3-county area, here, a private hospital, an emergency room, emergency medicine physician, texts me and says, we have a 45-bed ER, but we have 51 boarded patients in our 45-bed ER. So to those who don't know what a boarded patient is, that's a patient that's already been admitted to the hospital, and in an ideal world would already be upstairs on the proper floor in that hospital. But there are not enough beds upstairs that are staffed, fully staffed by nurses and other support staff for them to go to. So you either have to expand that capacity upstairs. And yeah, this was a big problem during COVID. It's still somewhat of a problem. It hasn't resolved completely. But the big problem was, well, I asked him, I said, this must be the flu. That's what I thought immediately. So I texted back, flu, question mark. And he's like, no, transfers into the hospital. So I don't have data on what percentage of those transfers are patients who would have been well served in their home community hospital if dialysis services were provided there. What percentage of these patients were end-stage renal disease patients? But we do, I do know from having, served in the various committees on the hospital where I work, or where I've done work over the years, that there are a significant number of transfers that come to the hospital strictly because of the fact that dialysis services are offered there, being treated for a problem that was very well been treated very well in the local smaller hospital. So I think that this is an important, good step forward, and that we should encourage our legislators to let them know that we're fully supportive of these changes, and hopefully encourage them to adopt them.
And I want to triple underscore what every word that Dr. Davis just said. And then the other aspect of this is the extra burden it places on EMS services, because we're coming from relatively small counties with very limited EMS coverage. And now you're taking an ambulance out of coverage and sending them to a much larger hospital. And we're starting to see some significant pushback from county boards of supervisors, or they're refusing to allow their ambulances to leave the county. So, this is a cascading issue that it's too late to get in front of, but we need to try to push it a little bit harder.
I should say that one thing we also talked about in our committee meetings that would come to the board hopefully very, very soon is clarification in the existing CON regs, which does not require statutory change, to make it clear on home dialysis, not requiring a CON. CON is about facilities, and the idea that there'd be a CON requirement for patients who can actually do this in their home, which would help make the problem maybe a little bit easier. So that will be coming up to the board in maybe the next.
The rural hospitals can keep the lower acuity. They'll also be able to transfer when one of their big problems is when they have a high acuity, they can't transfer it because all the beds are filled at the other ones. So if they could keep the ones they can keep, and then there's a coordination of care getting the higher acuity out, the small town physician and the rural hospitals could better survive. Dr. Waits.
I just want to make sure that Dr. Davis understands that the small hospitals can already have, without the CON that we're trying to pass, they can already have an in-house dialysis. This is only outpatient. So I don't think that's going to affect this transfer dilemma that you were just talking about.
Well, I think that if, depending on the hospital, it's not financially feasible to operate an inpatient dialysis unit if you can't also offer outpatient dialysis services.
Mm-hmm.
So there are hospitals that don't offer it. And the reason they don't offer it is because there aren't enough inpatient cases to make it financially feasible. But if you allow them to provide outpatient dialysis to people in the community, then it becomes something that's feasible and that's the operational.
But it also,
exactly right. They already can on an inpatient basis.
Yeah, and that's certainly all true for dialysis patients, but this extends to psychiatric patients too. That's one of the common cases that we end up boarding in emergency departments because of the very limited number of psychiatric beds in the state, not just in Mississippi, but all across the nation. And so oftentimes these patients are held in the hospital for days waiting on a transfer, getting inadequate care because there's not a psychiatrist involved at the smaller hospital. This would help alleviate those types of problems as well, and potentially at least could reduce some of the boarding issues.
All right. Any other questions about this?
I maintain my unanimous support of what our committee said. I do have concerns still about the dialysis for the outpatient. I just don't think it's going to work. I hope I'm around long enough to see if it really does work, because I hope it does. But I think it's going to have more possibility of hurting the existing very good system that we have in the state, which only has an access problem that Dr. Edney's map shows is not as dire as we were hearing otherwise. But again, I still have my support for the committee. I just have reservations that this is going to do any good. It has some possibility of hurting more than helping, is what I see.
Well stated. Well stated. All right, so Mr. Perry is bringing forward the report, the conclusions of the committee, which doesn't require a second since it comes from the committee. I think what we need to do next is just approve what Mr. Perry presented with the understanding of we hear about the importance of guardrails and we hear about the importance of unintended consequences, but that we'd like to encourage the legislature to proceed along the grounds, the conservative grounds that have been brought forward by Mr. Perry.
And that Dr. Edney and team can work with esteemed legislators like O'Brien and Sam Creekmore to craft the legislative language on the guardrails about the geographic footprint, the definition of rural and things of that nature.
The guardrail will be included in our report too.
Yeah, the guardrails, we actually typed out
It's implied in the language.
this guardrails. So we can give that report to the legislature so that they can see the specific, all the thought that went into how to try to craft those guardrails. And if somebody like Senator Bryan wants to talk more about it, we're happy to do so.
All right.
I was calling you out by name multiple times.
I can hear that part. Someone used the term goading you.
So let's go ahead and vote on this. Is there any further discussion? If not, all in favor of the CON committee's proposal? Any opposed? All right. So Mr. Perry, we've got a copy of your comments. Hello, Chairman. And
Sorry. Well, we just called you out by name multiple times. Don't worry.
Yeah. It's all good, really.
Good to see you. Why don't you come on up and sit in that last chair too? Oh, I know you don't like any attention though.
Mr. Creekmore is a method. I'm a bad.
Bob, this might be a good time. I'd like to just say hello to both of you and let you have a few comments. I know you just walked in, so I'll let him talk first. Yeah. He doesn't say very much though, so you might want to get ready. Chairman Bryan, it's so good to see you. We are always pleased you're here. You heard Mr. Perry's presentation of the CON committee.
Not well, he mumbled.
Yeah.
I mumbled that into the record minutes ago.
He did type out a copy of his comments though, so we'll get you a typed copy for your reflection. How are you doing? How are things going in the legislature right now, the Senate?
What time do y'all plan to adjourn?
Well, if we don't conclude by noon, I have failed. So we've got time.
I don't conclude by name.
It's good to see you. Chairman Creekmore, do you have any comments? Anything?
I hope to be sending our last year's CON bill to Senator Bryan next week.
All right, we'll get you the statement of the CON committee
Okay.
typed out.
Thank you.
Thank y'all for being here. All right, that's all the CON committee information, unless there's any further comment. That nominations committee is going to meet before the April meeting to bring us bring our slate of officers, which is an annual thing. So Dr. Edney, help me remember to get Dr. Anthony to call a meeting of that. Any new business that board members would like to bring up? Under old business, there's really no old business, except we do have a personnel matter and a potential litigation matter, which are both appropriate for executive session that we will need to discuss in executive session. So I would like to entertain a motion to go into closed session to consider executive session. Is there a motion? There's a second. All right. So we are going into closed session for our executive session, and it is a legitimate executive session matter because it deals with personnel and potential litigation. So we'll be going into executive session. We'll come get you after we're in session.